this month's seminar, we are very glad to have the Dr. Anne Marie Malfait from the University of Chicago. She'll talk about the joint. The title is the Joint Pain Matters: Lessons Learned from the Osteoarthritis. So Dr. Malfait is the a professor and chair of the osteoarthritis, the research from the Rush University at Chicago. And without further ado, Dr. Malfait, please take over.
Thank you, Dr. Guan. I will now share my screen and hopefully you can see it. Everyone can see my screen. Thank you. So thank you so much, Dr. Guan and Dr. Schumacher, for inviting me to speak. To all of you, I understand that you are a diverse group and I come from the world of osteoarthritis. So what I try to do for you is today is give you a broad overview about the problem of pain in osteoarthritis. And this here, can you see my cursor or not?
Yes.
That's
yes.
great. Yeah. But you see my cursor down below? That's exactly where I'm sitting right now, overlooking the skyline in Chicago. And these are my disclosures. So I will be talking about osteoarthritis, and please feel free to interrupt me if you have any questions. So I like to start with this sort of funny quote I read on the plane once while traveling to give a seminar. Somebody was reading a magazine that said in very large letters, "Other body parts may preoccupy younger men, but by middle age, men have their knees on their mind." And why is that? That is because they hurt. And so this is the only epidemiological information I will show from the National Center for Health Statistics. But it's very powerful, I think. It's a phone survey where people were called and they were asked in the last 3 months, which is the definition of chronic pain, as you know, have you had pain on most days or every day? And as you can see, around 20% of men and women say, yes, we have had pain on most days in the past 3 months. And around 7% of people say that this pain interfered with their daily activity. So this is high impact chronic pain. And what is very well described at length in many papers is that by far the musculoskeletal system is the major source of chronic pain in the world. And so this just shows this in another way here. But if you look at, how chronic pain really almost dwarfs other big diseases, cardiovascular, diabetes, cancer. And when we look in chronic pain, these are the numbers. So it's osteoarthritis and chronic low back pain, as well as other forms of arthritis, which you see here again. This is a global phenomenon: United States, Europe, Japan. Osteoarthritis, chronic low back pain, and other forms of pain that affect the musculoskeletal system, in addition to neuropathies and migraines. So I will be talking about osteoarthritis today, one of the leading causes of disability. The most recent numbers, 600 million people worldwide are affected by osteoarthritis. It's the third most rapidly rising condition associated with pain and disability behind dementia and diabetes, often because they have shared risk factors. The main major risk factors for osteoarthritis are age, as well as obesity, and then to the joint injury to the joint. I'll get back to that. It's the number one reason for knee replacement, and the lifetime risk for getting osteoarthritis is around 40% in men. It's almost 50% in women, and this risk increases to 60% with obesity. So it affects mostly the knees, the hips, the hand, the finger joints, and then the facet joints, the small joints in the spine. So, about 30, 40 years ago, we would think very much of osteoarthritis as a disease of cartilage. This is what we know about osteoarthritis. The cartilage gets severely damaged, and this is what causes functional issues. On an X-ray, what we see is here on the left, this is really end-stage osteoarthritis. You can only see the hard tissues. So the cartilage is gone, which is why the joint space is narrowing. There is sclerosis of the subchondral bone. There is remodeling at the edges of the joints. Those are the osteophytes. That's end-stage osteoarthritis. But now we think much more of osteoarthritis as a disease of the joint as an organ. So all the different tissues are participating in the pathology. So in the knee, that includes the meniscus. There's also the soft tissues, the synovium, the synovitis. There's all these things that are happening, which I will get back to. But for a patient, this is what osteoarthritis is. It's disability, loss of function of the joint, as well as pain. And so sadly, currently still management options for this chronic disease are really very limited. We just have to do symptomatic control, but that is largely inadequate. Non-steroidals are the go-to medication, but the effect sizes are small. Acetaminophen right now is no longer actually indicated mainly because it's not really efficacious in a chronic setting. Opiates are in some places in the country very widely prescribed for osteoarthritis, but they really shouldn't be because they do not provide sustained pain relief in osteoarthritis. What does work is exercise and weight loss. But these are two things that are very hard to implement in patients. And since there are no disease-modifying drugs for osteoarthritis that have been approved ever, for the large joints, the only thing that really can be done is joint replacement surgery. That is the definitive treatment. And it works. So in around 70 to 80% of people, this takes care of the pain, whereas around 20% of people still have pain and functional limitations after a knee replacement. Okay, and I know that most of you do not work on osteoarthritis, and I also know, since I talk to a lot of people about osteoarthritis, that this is often, considered a boring subject. And we already knew this in 1888. As you can see here, this was John Kent Spender, who worked in Bath in England, and he said, "Few things are so apt to cause a drowsy despair as at a medical meeting as the prospect of an academic discussion on osteoarthritis. And the field is so barren and the harvest is so small." This is what he said 140 years ago. And so we actually haven't advanced all that much. And so what I would like to highlight is some of the issues and why it is so hard to study osteoarthritis and to treat it. So the first thing that we really have to realize is that osteoarthritis is a very slowly progressing, most of the time, a very slowly progressing pathology that ends. I showed you this X-ray here, but that can be the end situation. That's not by any means diagnostic. That is just there for epidemiological reasons. But so this is the end stage, and this can be the end of a process that has happened over decades. And so when we do MRI, we can actually see that this is preceded by many changes in soft tissues. That includes the synovium. And if we could go very early, we would likely find very subtle changes in the cartilage or in the bone. And the way this progresses is influenced, or can be influenced by very many different factors. It can be mechanical factors, how the joint is loaded, genetic factors, systemic factors like obesity, menopause is a big influencing factor. So there's a lot of variability here in how this disease progresses. And that's just for the joint damage. But at the other side, there's pain, there's joint pain, and there's this sort of axioma in the field that these are disconnected, that there is a discordance between joint pain and joint damage. But that is really, if we just look here, it's only in the last 15, maybe 20 years that people have really started to carefully document how pain progresses in osteoarthritis using large cohorts. And so clinically, what it is it's a very insidious onset. People will all of a sudden have pain when they come down the stairs. It's very activity related. There's a very strong mechanical component, and that will last a few weeks, and then all of a sudden they have very long pain-free periods. Now, as the disease progresses, this pain can start radiating outside the joint, away from the knee. It can go up to the hips. And then as it progresses, the disease can, or the pain can become more persistent. And then in very severe cases, there can also be pain at rest. And people can all of a sudden wake up in the middle of the night with severe flares of pain. And now in most recent years, people have done large cohorts of quantitative sensory testing and have also found that there are neurosensory changes with changes in pain pressure thresholds. I will come back to that. Neuropathic elements have been also reported. And again, there are all these different factors, genetic factors, systemic factors, hormonal factors that can influence how this progresses. And so these factors can be overlapping here, or they can also be separate, non-overlapping. So this is one of the reasons why this causes such it is difficult to study, and we know very little about the relationship about what's happening in the joint and what is happening with the pain and the nervous system in osteoarthritis. And this particular lack of knowledge became very important, or very evident a few years ago, when people started targeting nerve growth factor for pain in osteoarthritis. And so all of you likely know nerve growth factor as a neurotrophin. And it became, it's a growth factor for neurons during embryonic development, but it's a target for pain in adult organisms. And so I won't spend time on that, but what was found is that some large companies, Eli Lilly, Pfizer, and others, started developing antibodies against that neutralized nerve growth factor. And that in studies and in clinical trials did exceptionally well to treat pain associated with osteoarthritis. And we had all expected for these to be approved by the FDA in 2021. Now, what happened is that the FDA did not approve, and all the big programs were stopped just a few years ago. And the reason for this is that in a subset of people treated with anti-nerve growth factor, people developed rapidly progressive osteoarthritis with actually subchondral bone collapse. And at the time, it was really not understood, and it still isn't, by the way, why this was happening. The reason why I'm showing you that is as a background to set the stage that we really have an enormous lack of understanding in the relationship. So between the musculoskeletal system, the joints, what's going on, the pain, and the role of sensory neurons in the joint. And this is exactly what in our lab we are studying. And the way, and so actually, for full disclosure, at the time, 17 years ago, I worked at Pfizer, not on the nerve growth factor program, but on the osteoarthritis program. And the people at Pfizer actually who developed anti-nerve growth factor, they were the pain group, and they never involved the osteoarthritis group at the time in this. So this came actually as a surprise to many. So for this reason, it is that I returned to academia and 17 years ago and decided to really try to unravel that relationship between joint damage and pain. And to this end, we used a mouse model of osteoarthritis that would capture this very chronic, progressive course of the disease. And so the workhorse model in our lab and in many other laboratories is the destabilization of the medial meniscus. If you look here in the left top here, there's a little ligament here, the medial meniscotibial ligament. And what that ligament does is that it stabilizes the medial meniscus. So if you make this very slight transection here, what happens is that you introduce a very slight instability in the mouse knee. Now, up until then, people had used for example, meniscectomy. If we all know that if you tear your meniscus or you tear your cruciate ligament, you get osteoarthritis, and you can mimic that in a mouse. But when you do that in a mouse, you get a very rapidly progressive osteoarthritis, and within 4 to 6 weeks, they have very severe joint damage. Now, what this model does is it introduces a very, very slight instability. And so what happens is that this osteoarthritis that develops is unusually slow for a mouse. So we do this typically in mice that are 12-week-old. All our initial experiments at the time were in male mice, C57 blacks. And so we do this surgery. And what you can see is a disease that we typically monitor for 16 weeks, 4 months. So that's long for a mouse. And what happens is that in the first 8 weeks, so for a full 2 months, almost nothing happens when you look at it. So you can do a toluidine blue staining. Toluidine blue stains the cartilage, is what you see here. So I don't know if you can even see that, but here there's a very slight lesion in the cartilage. So this is exceedingly mild. And so you can see this here on the left-hand side quantified. This is for 8 weeks here after surgery, hardly any cartilage damage. But then in the next 2 months, between 8 and 16 weeks, you see a very rapid progression. And now you see real severe joint damage by 4 months later. And so here the cartilage has worn away. You have large osteophytes. So if you did an X-ray, this would be like the X-ray in the knee I showed you earlier. So this is real end-stage osteoarthritis. And so we take advantage of this slow progression now to start looking at different pain-related behaviors that may develop in association with this progressive joint damage. And so I just listed some pain behaviors here. I won't show you all that, but what I would like to show you is that if we do longitudinal measurements, is that we can see that pain develops in a very specific manner in association with progressive joint damage. So the first thing that we see is sensitization to mechanical stimuli. And so within 2 weeks, we see that the mice develop knee hyperalgesia at the level of the operated knee. So we just squeeze the knee. This is all done in a blinded manner. And so mice, we can put 450 grams on that knee and the mice don't care. But when we do a surgery, whether it be a DMM surgery or a sham where we open the whole joint, they will withdraw their knee now at 250 or 300 grams. So they've been sensitized to mechanical stimulus. And so you can see in the blue triangles that the hyperalgesia is at any given time worse in the DMM mice compared to sham-operated controls. So that's something that happens very fast. The other thing that happens very fast, the 2-week time point disappeared here, but it's actually is mechanical allodynia appears in the ipsilateral hind paw. That happens very fast. The shams get it too. I didn't put the shams on here, but the shams go back to baseline by week 6 or so. But the mice with osteoarthritis have mechanical allodynia for the duration of the experiment. So sensitization happens very fast. But when we look at things that may be more indicative of real pain, that doesn't occur immediately. That takes really quite a while. And so one of the things that we do is we look for weight bearing on both hind paws. So we put the mice on a scale. And so if it weighs 30 grams, it will put 15 and 15 on each hind paw. And so when we do this, there's a sham versus a DMM. So we can see here, like at week 4 or at week 8, when these mice have severe allodynia and hyperalgesia, they still happily rest their weight on both hind legs. But by week 12, they start taking the weight off the hind leg with osteoarthritis. So these are weight-bearing deficits that are indicative of pain, and that is really something that patients with osteoarthritis do also. They take the weight off the affected limb. And the sensitization is also something that the sensitization to mechanical stimuli, it occurs in all animal models of osteoarthritis, but it also occurs in people with knee osteoarthritis. And so we can look at pain pressure thresholds in quantitative sensory testing, and we can do we can use von Frey fibers to test allodynia, and so a lot of these studies were led by Tuhina Neoji at Boston University on very large cohorts of patients. And so what has been reported is that people with osteoarthritis have lower pain pressure threshold at the OA joint, but also at sites away from the joint. Importantly, sensitization measures have been associated with the severity of knee pain. And what I think is really interesting is that pressure pain sensitivity at the knee has been reported to be a major risk factor for developing persistent knee pain 2 years later. So just as in the mice, is that the sensitization at the knee precedes ongoing pain in the knee. So it's something that we can look at. So I'm showing this to you to show this progression of things that are happening in the joint and with the pain in this surgical model. And at the same time, we can see that there are neuroinflammatory processes that are happening along the neuraxis that are also time dependent, which is what I will briefly show you. So when things are happening in the joint, is that we can see that over time there are gene expression changes that are happening in the dorsal root ganglia that innervate the joint. And we typically look at L3, L4, L5, which is where the cell bodies mainly are located. And so years ago, we just looked at, we did RT-QC PCR to look at specific genes we were interested in, and we found, for instance, that the message for MCP1 and nerve growth factor were very strongly upregulated, very specifically at week 8 after surgery, not at week 4, not at end stage, but very specifically at week 8. And then a few years later, we did microarrays. And what we did is we took different time points. We looked at post-surgical pain by looking at shams. We did early OA pain. So this was 4 weeks after surgery. And then we looked what we called persistent OA pain. This was, I remember it to be 12 weeks after surgery. And we looked at differentially expressed genes in these DRGs. And you can see how there's actually very little overlap between those 3 groups. There's only 8 genes that were regulated in all 3 groups the same. But when we look in persistent OA pain, what we saw was an imprint of genes that were related to neuroinflammation. I'm just showing you here because I just think it's kind of interesting, but these are human dorsal root ganglia that we took from very old people, 3 men, 3 women, who were in like 95, 96 years old, post-mortem, of course. And so we just look for cytokines in these dorsal root ganglia. And so we could find in all 3 males, there was more CCL2 present than in females, whereas in females, there was more CCL3 present than in males. So that's just some human DRGs that I wanted to show. But going back to the mice, so what we are finding is a lot of macrophages in the DRGs, and we see this again in a very time-dependent manner. It's not there at 4 weeks, but they are increased starting at 8 weeks and 16 weeks post-surgery. And then just a brief experiment where we used mafia mice to deplete the macrophages. They're just depleted everywhere. It's not a perfect experiment, but they were depleted from the dorsal root ganglia in a vehicle-controlled experiment. And as you can see here, when we give the agent here is how the knee hyperalgesia is partially reversed, whereas also the weight bearing is reversed by depleting the macrophages, suggesting that we could go after macrophages as a therapeutic target for analgesia in osteoarthritis. And then finally, again, because I want to show this sort of very time-dependent chronology we find in this model, is that we can also see microglia in the dorsal horn, and there's real microglia activation that happens. Again, this is all done in a blinded manner, but it doesn't happen early in the disease. We really see this microglia activation starting around 8 weeks after surgery, 16 weeks after surgery. So I wanted to show you this. The DMM model is really has been the workhorse model, but now many labs, including ours, we use the partial meniscectomy model. The reason is that females are also very susceptible to osteoarthritis in the partial meniscectomy model. So we started using that more and more. But these models captures the slow progression of human osteoarthritis, and so we can detect sensitization to mechanical stimuli preceding pain, and we can see these progressive neuroimmune changes along the nerve axis in the DRG, in the dorsal horn, and now there's also some information coming out in the brain, but it's still very, very limited in models of osteoarthritis. We have some pilot data, but it's really too early to show them. Now, so everything that we do until now has really been in the peripheral nervous system, and while clearly pain is in the brain, we don't study the brain for now, and I think for now that's fine, because there is this very strong evidence that there is strong peripheral drive for pain in osteoarthritis, and I've already told you that the vast majority of people find pain relief with total knee replacement. So I think it is important to really dissect in great detail what is going on in the periphery. And so this is why we are focusing on this unit here. So when we talk about the disease as an organ, and what we are missing in the periphery is really information on the nerves, and we spend a lot of time trying to find out where are the nociceptors in a joint, and the reason is actually here a very simple experiment in the mice that we did many years ago, but I've already shown you induce osteoarthritis in a mouse and they get knee hyperalgesia. So they become sensitized to this mechanical pressure at the knee. That's what I showed you But when we do this and we take these mice at this 4-week time point here and we inject lidocaine intra-articularly, and this is a vehicle-controlled experiment, we can reverse this transient reversal of that knee hyperalgesia. And so that's an intra-articular injection of lidocaine. And what that was telling us is that this behavior is mediated by intra-articular nociceptors, right, inside the joint. So we were wondering, where are these nociceptors? And so then we found out that the literature on that is actually or was very limited. There's old anatomy-rich literature, beautiful, out of Germany, a lot that shows that the joint is really abundantly innervated everywhere except in the cartilage. But where are the nociceptors, free endings? We don't really know. This is a study I like to show that actually happens to come out of UCSF, where these two orthopedic surgeons, Dr. Dye and Dr. Dye, who are brothers, they decided to poke around each other's knee, inside each other's knee, without anesthesia. And then they said, does it hurt? Yeah, I see someone laugh. Yeah, it's a very funny paper to read, actually, because it's very well written, because it hurts a lot. And so where it hurt a lot is where I drew the red circles here. So where it hurt a lot is the fat pad in the knee, is the insertion site of the cruciate ligaments, and then the lateral side, the lateral synovium, hurt a lot more than the medial synovium. And this was interesting because as we have started doing careful mapping of where nociceptors in the joint are using mice, we actually found that sensory innervation of healthy mouse knees matches these locations in painful human sites. So what we find mostly, and I'll show you this in detail, is we found a lot here of nerves in the lateral synovium, in the infrapatellar fat pad, also in the anterior meniscal horn, and then here, this is the cruciate ligament insertions. But I'll show you that in better pictures in a minute. So what we are looking at here, we were lucky enough to get NAV 1.8 tomato reporter mice from John Wood. And so we use this as a marker for nociceptors. And so here you see we can use these. These are the dorsal root ganglia of these mice. These are the nerve bundles. Here you see how these reporter mice are entering the dorsal horn. So we started using these to find out where are the nerves in the joint. And so I showed you some of that earlier in healthy joints. But what we learned from this is, and we've published the healthy ones, but what we learned from this was remarkably that the nociceptor innervation in joints with osteoarthritis is very different than in a healthy joint. And so we found sprouting of nociceptors specifically in the medial compartment. So for those of you who don't know, I haven't told you this yet, but surgical osteoarthritis in mouse joints is a medial compartment disease. Because, there is more weight that it gets put on. Also in people, it's often a medial compartment disease. But so we mimic that in mice. And so we see nociceptor sprouting very specifically in two spots. So first of all, we see nociceptors that sprout in the medial synovium. So here you see so that's not there in the controls. We've published that. I'm not showing that, but you see this sprouting in the medial synovium. And this here shows this again chronologically. So this is the lateral, this is the medial synovium, like I said before, and like in the knee of the brothers Dye, there is more nociceptive innervation on the lateral side than on the medial side. the lateral side doesn't change in osteoarthritis, but in the medial, so here are the shams, there's no change, but this is in the mice with osteoarthritis 4, 8, 16 weeks. So there is this sprouting that we observed. So more recently, we have developed a method. We do a disco clearing of entire mouse knees. And so we've developed a method to look at that. This here, so the blue here was endomucin for the vasculature, and the red is NAV 1.8 that we, and so what you saw pop up there is that cluster in the medial synovium. So it's a cluster of vessels and nerves that are sprouting in the medial synovium, and so we can quantify that also. And so what we are currently doing is an experiment where we look. This is the partial meniscectomy model where we're looking at different time points and study this sprouting. So that's the medial synovium. The other place where we find this very distinct sprouting is right here in the subchondral bone. So here you see the subchondral bone. And so these are channels. I'll show you that in a minute, more of that. But these are not there in the controls. And so there are channels with nociceptors inside these channels. And again, we've actually looked in 4 different models. So the DMM, the partial meniscectomy, this here, the ACLR, that's ACL rupture. We're doing that in collaboration with the group of Tristan Merz in ETH Zurich, and that's a closed model. So instead of doing a surgery, they're just putting a weight on the knee, and that ruptures the anterior cruciate ligament. That's quite an aggressive model, takes 4 weeks to develop. And then this here is primary age-associated osteoarthritis. So all mice, C57 black 6 mice, they get osteoarthritis as they age. And that's about full-blown by age 2 years. And so what we are finding is that in all these models, we see this progressive development of these channels. And again, we have published that if you are interested, we can actually really measure how these channels are getting longer and longer and are getting closer and closer to the cartilage. So you see that here. So here we zoom in on this joint. What you see here by the white arrows, that's where the cartilage has eroded away. And so we really see how this is the bone marrow here. And so what we really see is these channels, they almost seem to grow towards this articular cartilage that is damaged. And it's always underneath. So when you go in the non-damaged areas, you don't find that. And so when we here, what I'm showing is we took like a whole bunch of mice, more than 30, in all these different models, and we just looked at the correlation between cartilage damage and the numbers of channels with nociceptors that we could see in the subchondral bone. And you could see that there is quite a good correlation between those phenomena. So we further also looked a little bit what happens, what is the role here of these intra-articular neurons. Here we came up, and I can't go into all the details, but we try to we injected AAV carrying diphtheria toxin intra-articularly in these NAV 1.8 Cree mice. And so we did find, and I can't show you that really ablated the intra-articular neurons. But when we then do a DMM surgery, so here in the controls, this is now a TUB3 staining, but we see again these channels. And so this was prevented, this sprouting was prevented in the mice where we had ablated the intra-articular nociceptors. And that was associated with reduced weight-bearing pain. So these mice had, they still happily put weight on both hind legs 16 weeks after DMM surgery. Now, at the same time, we also found actually that these mice were to a certain extent protected from cartilage damage. So you can see this here, 16, 17 weeks after surgery, these mice had less cartilage damage. So they still had synovitis, but they had less cartilage damage, suggesting that there may be a neurogenic contribution to cartilage damage in osteoarthritis. In humans, it has been shown that CGRP neurons are present. That's the work of David Walsh, and it's actually based on this work that we started looking in the mice. But he reported that these channels, these osteochondral channels that come from the bone, go through the tide mark, go into the cartilage, and he reported the presence of CGRP nerves in there, and they're correlated with pain. And so here what I'm showing you, these are very new data, but we're looking at light sheet microscopy now of human osteochondral plugs. So this is the bone here up top. That's the cartilage that you see. There's the tide mark here. And so we stained with PGP 9.5. So that's ongoing work. We are trying to quantify this, but so you can really see this network of nerves that are forming there in the human subchondral bone. So currently we're doing this on a well-defined set of normal versus osteoarthritic osteochondral plugs. So nociceptor sprouting seems to be a phenomenon that is inherent in the pathology of osteoarthritis, and it occurs in the medial synovium and in the weight-bearing portions of the subchondral bone, and it may play a role in pain as well as in joint damage. And so because of that, we are of course interested in potential mediators of this structural neuroplasticity in osteoarthritis, because if we can identify drivers of this process, there may be targetable processes in there that we may develop for pain or even for osteoarthritis. So I'll just give you a few examples here. So the first sort of the most parsimonious explanation would be, oh, it's nerve growth factor, because that's one of the things that nerve growth factor does. It makes nerves grow, and it's very well documented that the synovial fluid of patients with knee osteoarthritis contains elevated levels of nerve growth factor. And again, this is from David Walsh in Nottingham. He many years ago showed that if he took patients that had the same level of chondropathy, cartilage damage, but there was a group that had no symptoms versus a group that had pain, that he found that nerve growth factor was elevated in the synovium and was elevated in these osteochondral channels that I showed you earlier. So we recently took some naive mice, no osteoarthritis. We actually did this during the pandemic because we were not allowed to do surgeries. And sorry, I had to click that out. So what we did here is we took healthy mice and we injected nerve growth factor. And I believe it was 8 times here over the course of 4 weeks. And so what you can see is that when this is a control, here is a saline control, and we focus on the medial part, again, we see that nerve growth factor itself can make this sprouting happen. And interestingly, it is specifically in the medial compartment of the knee, of this healthy knee. Okay. And here we have this quantified. So on the medial side, we see how nerve growth factor is inducing sprouting in the medial compartment of the knee. So that is just looking for nerve growth factor. Currently, we are doing experiments with anti-nerve growth factor antibodies from Eli Lilly that were mouse anti-nerve growth factor to see the effect on nerve sprouting, but that's an ongoing experiment. We also have as part of of this big rejoin project, which is a consortium that is part of the HEAL initiative, and we're also looking for potential molecular drivers of this injury-induced nociceptor sprouting. So, for example, we are doing these paired synovium DRG transcriptomics. So what we did here, and this is together with Tristan Merz again in Zurich, we did the model where we do an ACL rupture, and then 1 day, 3 days, and 7 days, so immediately after injury, we collected the synovium and the matching lumbar dorsal root ganglia, and we did bulk RNA-seq in these tissues. And so what you can see is that you can have, you really have the shaman 4 very discrete groups that appear in the synovium, and also in the DRG. It's less well defined, but there are 4 groups that can be identified. And when we look at pathways here, what you can really see is that that early on, like 1 day after the ACL rupture, what you see is neuroinflammatory responses that are activated in that synovium, and then that dies down by 7 days. But by 7 days, you see regulation of neuronal projection development. And when you look in the dorsal root ganglia, for example, very quickly, 1 day after that joint injury, you see pathways of axonogenesis that are activated, and then that diminishes, and these other things are happening. And if we also look at single cell RNA-seq in the synovium, what we can see here is a very rapid influx of immune cells. So here, within 1 and 3 days in the synovium, we have these myeloid cells, which is concordant here with these neuroinflammatory responses. And then later it's the fibroblasts, the sublining and the lining fibroblasts that are activated, which is, concordant with these neuronal projection development here. And so we can also try and look at how these things may be talking to each other by looking at these interactome things that are happening. So, for example, what we are seeing here, if we look, this is spatial transcriptomics that we did because, we're interested in this nerve growth factors. So nerve growth factors secreted by the synovium may work on the track A, of course, in the dorsal root ganglia. So what you see here is a spatial transcriptomics that we recently did with Tristan Meds on the dorsal root ganglia here. And so you can see that these NGF receptors, track A and the P75, are broadly expressed, of course, but then when we go look here, we see, for example, we're interested in semaphorin 3 and its receptor plexin. And so the semaphorin 3, you can really see how it's here specifically expressed in the lining of the synovium, and the receptor is here present in CGRP expressing dorsal root ganglia cells. So that's sort of an approach that we are taking now, and we're also doing this in human in human tissues. I actually haven't gotten human data yet, but this is just a theoretical exercise we did as a sort of feasibility where Mike Newton and Hannah Swan, and also part of the Rejoin consortium, looked at big data in synovium from single cell RNA-seq, and they looked at the interactome with an existing DRG database, and then looked at how these things might be talking to each other, and found that multiple cell types, fibroblasts and macrophages always come up, were implicated in these OA-enriched ligand expression. So that's what we're looking at. And oh, something's wrong here, sorry. So we currently, as part of, and that's where I will end it, but part of this rejoin is that what I showed you as an example in the mice, we're trying to do in people by collecting, together with Martin Lotz's group at Scripps, we're collecting knee tissues and matching dorsal root ganglia from deceased people and also their facet joints and their intervertebral discs. And so we're basically studying what's going on with their innervation, the joint damage, but then with the expression of different molecules. And so we're trying to identify targets there. So I will leave it at that. But if you remember one thing, is that, osteoarthritis, but actually the musculoskeletal system is the leading cause of chronic pain in the world. And we really need to study those, I think, in more depth. One of the hallmarks of osteoarthritis pain is a hypersensitivity to mechanical stimuli. I had more slides, but I skipped them. We're studying the role of piezo2 and piezo2 as a potential target in osteoarthritis. Anatomical neuroplasticity is a hallmark of osteoarthritis, and it happens very early on in the disease. And the sprouting nociceptors may play a role in pain, but they may also play a role in joint homeostasis. There are neuroimmune interactions that happen all along once the joint has been injured. And so while overall this looks like a very complicated picture, it also sort of opens a lot of opportunities, because we may be able to intervene at different levels of the pathway, especially soon after a joint injury. And I will leave it at that. So these are all the people in the lab that are doing all the work. And Rachel Miller here up top is my co-PI. So we are a 2-PI lab. And then we also work closely with Richard Miller at Northwestern University. And I would like to thank a lot of collaborators, including here on the right, all the collaborators of the Rejoin Consortium. And if I may, I would like to let you know that we have here in Chicago, the Chicago Center on Musculoskeletal Pain, which is specifically aimed at trying to study mechanisms specifically in musculoskeletal and rheumatic diseases. And if you are interested, you can become a member of that. We do have pilot grants. It's a new center. We've already awarded 15 pilot grants. So it's a P30 supported. And we have awarded 15 pilot grants. The idea is to bring together neuroscientists and pain researchers with musculoskeletal researchers to tackle this problem. And I will leave it at that. Thank you.
All right. Thank you, Anne-Marie. So I see Alan has posed a few questions. Maybe Alan, you just unmute yourself and ask directly.
Thank you, Anne-Marie. It was great talk. Really enjoyed it. I have a couple of questions. First is a simple one. So you sort of poo-pooed NSAIDs, but you'd never mentioned steroids, which obviously are used all the time. Does that mean you don't advocate their use?
Oh, sorry. Actually, I should add that to my slide. So no. So steroids are recommended. They are for intra-articular. So they are intra-articularly given, and they're approved, and they are recommended. The thing is that people shy, so they have their long-acting, slow-release steroids that are being given. The thing is that over time, they have been shown to have a negative effect on the joint tissues themselves. So
Right.
cartilage doesn't particularly like steroids, and so that's one of the reasons. The
Okay.
other thing is that well, you can't do it in all joints, right? I mean, giving it into a hip, you need ultrasound. That's already harder to do. So its use is limited.
Okay. The other quick question, and because I know others have questions, you did emphasize the macrophage, but you also even talked about a microgliosis in the cord, which is usually only occurs in a neuropathic pain setting where there's actually nerve damage. So one of the two questions is, are we talking about sprouting of intact afferents or also damaged regeneration of damaged afferents? And then related to that, is gabapentin at all helpful?
So are you telling me that microglia in the dorsal horn, that is telling us that is a neuropathic event? Is that what you just said?
It's a nerve damage induced event.
So you don't think that if we see microgliosis that could happen in the dorsal horn, that could happen without nerve damage?
I'd be surprised.
Oh,
Very
really?
surprised. We
Now,
do big
gabapentin.
inflammatory lesions, CFA, things like that, that does not produce a microgliosis.
Maybe it's not long enough. See, I mean, because we have to wait a really
Okay, good point. Yeah,
until
fair
we
enough.
see that. So I am
Interesting.
like we've looked for ATF3 in the dorsal root ganglia, and we've never found it in MRI.
Oh, that is
Never,
significant.
never.
Oh, interesting.
Gabapentin, yes, gabapentin is used in osteoarthritis and is also recommended. So if you look in the guidelines for osteoarthritis treatment currently, acetaminophen has been removed. NSAIDs is the number one. Steroids are okay, and gabapentin if the rest fails.
Thank you.
All right. Tamara, you have a question?
Tamara,
Hi. Hi, Emery. Fantastic as always.
Hi.
I just want to say, in the response to the last conversation that was just going on about neuropathy, certainly neuropathies are indicated. Neuropathic pain-like states are indicated in some patients with osteoarthritis pain. You said that at the beginning of the slides. And so I'm just curious about when and whether you would see ATF3. Obviously, in the MIA model, it's widely reported to induce ATF3 expression. So I think time course, as you brought up, is a really nice point to make because I think it might be very time dependent. And it might associate with different pain phenotypes, with broader phenotyping, as you indicated in the initial slide as well. So I think there's more to be learned about that aspect of things.
Yeah.
In relation to my question, the multiple NGF injections was really interesting, really exciting with the sprouting. I'm wondering, and it sounds like that's kind of might still be ongoing, and I know you have some stuff out there, but did you guys see changes in cartilage, like in relation
we
to
actually just published last week this paper.
last week? Okay, that's why I'm like, I don't remember seeing it.
So there's a lot. I couldn't go into that, but the nerve growth factor story is really complicated. So if we inject nerve growth factor in naive joints, and we really just did that because we couldn't do anything else, and then all this stuff happened, you basically cause, paradoxically, you cause osteoarthritis, except there's very little cartilage damage. There's osteophytes that grow, there's synovitis that occurs, there's bone changes. The cartilage damage is very limited.
Through our anesthesia program,
Very cool. I can't wait to read it. I'm going to find and download it now.
It's really baffling, and so we just got. I would like to study that further now because I frankly don't understand it. I just add to the further enigma of the whole NGF story and the joint.
Well, that makes sense with the other observation you had in relation to blocking the sprouting, improving cartilage outcome. So that's what brought it to my mind.
Not what we had expected. We had expected it make it worse.
Right.
All right. Anna, you have a question?
Oh, yeah. So I was just wondering, it's really striking that you only get sprouting in the medial synovium, and that seems separate from the differential loading of the medial plateau, because it's just NGF induced. But yeah, do you have any thoughts on that?
Yeah, so yeah, it is not separate from the loading because mice, just like human, they put more weight on their medial compartment. So we are indeed using this now as, there's clearly a relationship between the loading and the inflammation in the joint and the sprouting. And so we're also looking at the role of piezos, for example, piezo 2 in the sprouting. And we can prevent the sprouting by knocking out piezo 2 from the nociceptor. So there is a relationship between the mechanical thing that's going on and the NGF, but we haven't gotten it further than that yet. But it's reproducible. It's always in the medial side.
All right. Alan, you have another question about ATF3?
Yeah, back to the ATF3. I mean, well, actually, Jean-Gui, you're the ATF3 expert, but I'll ask this question. So the timing issue becomes really interesting because one of the things about ATF3, it's induced when there's nerve damage pretty reliably, but when the nerve regenerates and makes sort of stops regenerating, it makes contact, ATF3 is shut down.
Oh, okay.
And so the question is whether you looked at different time points? No. So
maybe we should do that. That's a good point. We will do that. So that's I did not know that. So that'd be really good.
Yeah, and Jean-Gui is the expert. He would know the answer to that.
Well, not accurate, but I think a very good example of what Alan says is the crash model. You have the ATF induction, and once the nerve regrows touch the end organ, then the ATF3 signal goes down. So I think that correlates well with what Alan says. And well, I have my own question. So I'm a pain doctor. I'm actually doing the steroid injection into the joint to treat osteoarthritis. But the fellow always asks me, what does steroid do? I can come up with some story, but I've hearing him the expert. So what does steroid do if we inject into the
Well, it's anti-inflammatory, right? I'm not the expert. You know what? I'm always ashamed to say that, and every time I say I would like to do it in our mice ones to know exactly what the steroids do in our mice.
Yeah, so certainly the teaching, if we call is we reduce inflammation. I guess that is probably true, but I never knew whether let's say you have all these sprouting, all these things, whether the story has anything to do with the sprouting or anything, it just go beyond the inflammation reduction. Is that something, well, clearly clinically certainly, effective, right? Also, it has,
and it lasts about 3 months, right?
Yeah, right. So you have one injection, you have, about roughly about 3 months of benefit. So that is something,
we have never looked at what steroids might do on the sprouting. We have done one experiment not long ago where we injected steroid intraarticularly 4 weeks after the surgery and looked at the pain, and the pain went away for about 4 weeks.
Yeah. So
works
in the mice. Yeah.
I have another question. So I was, I don't know what you'd call me. I almost left university when Renat developed the anti-NGF. I was very involved with that work. But of course, the FDA, and you described how the FDA wouldn't approve it because of off-target joints. But has anyone ever, or you tried, direct injection of anti-NGF into the diseased joint to keep it away from the bad joint, the other joints?
I don't know why nobody has done that.
No, that's not true. They did. There was a whole company that did that.
Who did
They
that?
did the whole company that did that, and it did very well, actually.
I've never seen any.
And it's published, and they went on and I think did a phase 2 study, but they stopped. Yeah.
Which joints were that, Nancy?
Yeah, it was the knee. It was the knee. It was very effective in the animals, and then they put it in the knee. Yeah, but it was only done once, and no one went further. Sorry about that.
It just doesn't make any sense.
I have never seen that paper.
I'll find it. I actually had to review the thing once it came out. So yeah,
I've seen one
it's really
paper in
there.
a rabbit. Was that the one in a rabbit? I saw one in a rabbit.
All right, but I'll find it for you all. But yeah, it was
great.
effective. It was effective in the animal studies and had some efficacy in the clinical studies, but I believe it was only one injection and they didn't go any further.
Doesn't make any. That's so weird.
What I would like to do, so one of the things in the paper we just got out where we injected nerve growth factor in the naive joints, right? And we induced the sprouting. A major thing that we induce is osteophytes. So by injecting nerve growth factor, the osteophytes start growing, which I think is fascinating. And for me, so I would like to try anti-nerve growth factor. So when people get osteoarthritis in the hands, for example, they get huge osteophytes, and that hurts when they're growing. That actually hurts, which sort of. So I would like to develop anti-nerve growth factor for injection in finger joints, where I think it might help the pain and the growth of the osteophytes. But I haven't seen that in the knee. I'm sorry, I've actually never seen that.
Well, thank you for a great talk. I really enjoyed it.
Thank you. Thank you for listening.
Okay.
All right. So the next seminar would be in September.